All right. Hey, everybody. Thanks for joining us today. My name is Emmeline. I'm a counselor here at Williamsville Wellness, and today I am joined by,
Dr. Lyndon Javier,
yes,
Clinical Director.
Jeff London's our clinical director here. He's been with us for almost 11 years, which is a super long time. Today we're going to be talking about the topic of schemas, which I know is London's favorite. If you've ever been here with us or you know London, you know he loves schemas. So let's talk let's talk about the history of schemas. Tell me a little bit about what you know about schemas and its utilization in therapy.
Yeah, I could start by saying that I didn't start with schema therapy in my theoretical development. I was doing my doctoral work in New York. New York City is known for psychodynamic theories and orientations. So a lot of my initial experiences were in the psychodynamic realm, object relations. And it gave a good sense of the history of psychology and therapy, as well as attachment. Attachment plays a role.
Right.
When I was on internship in Miami, I learned more about schema therapy from one of my colleagues in the fellow interns,
Okay.
and I liked it because it was an integrative type of
Yeah.
approach that includes. It does consider those early childhood phases, and it considers attachment style. It considers the maybe genetic factors, but it also incorporates some of the cognitive behavioral approaches that we like to use, and so it's a very integrative approach that considers these relational patterns from childhood, adolescence, to adulthood. So what we know is that when Aaron Beck was developing CBG, he used the term schemas, and schemas is a from the Greek word where framework, structure, plan.
Okay.
How we see things. So you use schemas in developing CBT, I guess in the 50s, and then that became the basis of those approaches, or more behavioral. But schema therapy, Jeffrey Young would develop that into a separate type of treatment approach. Like I said, included the attachment styles, the childhood development piece, the interpersonal patterns. So I really like it combined lots of different approaches.
Yeah.
And it was effective in the work I was doing with clients.
Yeah, very all-encompassing. I think when I think about schemas, I kind of translate it into the building blocks on how we integrate or interact with the world almost. These are things that maybe shape my interactions, in friendships, romantic relationships, at my work, all the different areas or facets that I'm involved in. Schemas kind of propel me into how I'm going to interact with that, which is cool. And it's obviously very necessary because it's a part of everything we do. Tell me about the first experience like integrating schemas into therapy. How was that for you?
I think of cases more. Most of my early work was with college student population, college counseling centers, and you think that setting is might be easy and all, but there's lots of trauma, mental health issues, substance use are all in the mix there with students I work with. And I think of a case where I was working with a young female doing outpatient therapy at a counseling center, and there was all these family patterns of trauma, abandonment, instability, and the person was in college now and was like, "Oh, I left that environment. I'm all good." They feel like I should be feeling great, and she was extremely depressed and was using substances, and though she's highly intelligent, she was self-destructing. And as I started working with her, I introduced the concept of schemas, and I gave her a framework to look at herself in the world and her relationships. And the interesting part about her is that I had a couple sessions with her. Second session, we made some like deep connections on the schemas. Third session, I think it was, she canceled. She said, "No, can't make it." Well, not even canceled, sorry. she didn't show. She didn't show. So then I called her 2 times, and I was ready to like close the case. And then she eventually called me back and said, "Oh, I was sick," and she can't continue therapy. But fast forward to the second year I worked with her.
Yeah.
She continued to have lots of mental health crises. She was hospitalized multiple times for suicidal ideation, and got to the point even where the school was looking to medically discharge her because of her instability. I had to basically fight with the psychiatrist and my clinical director sided with me to let me continue working with her. But we were able to make some significant headway in helping her develop strategies for distress tolerance, for understanding her family dynamics, for ending up a correct experience in therapy. And she ended up graduating and doing really well. And I asked her about it later towards the end of treatment. I go, "Well, what happened in the beginning? Like that she canceled it or no-showed." And she said that she, felt like I could really help her. And she was really scared that, obviously with the schema of like mistrust, she's right. So for her to take that leap of faith was fearful to her. But she said the fact that I called her one more time, that she said, "Name something," she said, "this person cares." And that was what led us to have good breakthroughs over the years. And but it really fit the way she thought. A lot of the clients I work with think, they look at people. We're not trying to go back to childhood and blame our mom or something like that. It's looking at some of these things are genetics that we're dealing with. It could be a temperament. It could be an anxious temperament. It could be a very impulsive kind of temperament. Those are things that we might inherit. But the early childhood environment, all the way up to age 25, is instrumental in shaping that individual. So looking at those dynamics and understanding them gives the client a chance to then start to make changes.
Yeah, up choices that and I think you bring up a good point of, sometimes people will be like, "Oh, well, the past is behind me. I'm in college. I'm creating a new life. Like I'm moving on. That's not a part of me anymore." But mainly it's that I'm just not aware. And I think schemas has that ability to bring on self-awareness where I can start to see, oh, wow, yeah, this does really impact me. I do have a deep-rooted fear of abandonment and a wound from that hasn't been healed, that I haven't been addressing because I've just been ignoring it. And I can see where, in the client's shoes, it's scary. She hears, "Oh my gosh, these are all the things, that are impacting me and causing me to struggle and making it difficult for me." And then the avoidant piece, the mistrusting schema, "I don't want to come back. I don't want to do anything about this. Life felt a little easier maybe when I was like, ignorance is bliss, living in the shadows, didn't know about all of it." So schema is being able to bring about that self-awareness, that chance to look inward. But you have to do in schema therapy.
The client feels really understood that and scared at the same time. This makes all this makes sense. And their initial reaction might be like, "Oh crap, basically this is I'm gonna have to deal with this. Plotty quick fits." It's not like I just moved to Iowa and everything's good. It's gonna be a long process. But with the right approaches, and so we're really trying to empower them. So on one hand, we're helping them see the patterns and develop some accountability for them here and now, but we're also really focusing on empowering them to have a voice, to be understood, to feel like they can assert their needs. So it's very personal, as Zeb said, that they can't just develop some techniques, to manage the distress. Everything's great. They would have to then actively make changes in how they navigate relationships and express their needs or set boundaries. So I love that because it has all those components and it gives you a good framework to follow. And there's been a lot of evidence showing that schema therapy works really well with personality disorders, particularly borderline personality disorder and narcissistic personality disorder. The clinical evidence is that it's a good one, the better modality to address those types of personality issues.
Yeah, which makes sense. I think there needs to be this element of trust in any type of therapeutic relationship dynamic, but especially with schema therapy. We're looking at these very deep-seated, deep-rooted issues so that therapist, client, relationship is pinnacle, right? So when you're looking at personality disorders, borderline, oftentimes there's tons of fear of abandonment. So that connection is vital. And then narcissistic personality disorder, getting somebody with that disorder to look inward is very earth-shattering at times for them. So being the therapist, the solid ground that they can trust, that they can be open with, is very important. And I know the case you talked about, it's like she really had the ability to trust you. How do you cultivate that in the therapy room with clients, the trust?
Yeah, that case was also a little bit more. It was interesting that she was an art major, really, really talented art major. And disclaimer, I'm not an art therapist at any capacity, but she would sketch some of her emotions when she's waiting in the waiting area before seeing me. And she had trouble using the words to describe her feelings, but she showed me these incredible images of her in a dark corner or something like that. And I would use that to process her emotions.
Yeah.
And it allowed her, that was a vehicle that helped her to communicate her emotions and needs. She did that. We did the camps for years, the suicide assessment for years, and it was chronic suicidality, but it was fluctuating. But having that dialogue about the depression, the SI, that was meaningful. We stopped doing the camps after 3 years. He was stable. I was stacking it, but the rapport was developed because I was able to be flexible in the way we process emotions. I mean, that was, I think, more her idea with the artwork, and then it was also, I think it was a time that which is hospitalized at VCU. My office is by a couple blocks away. Yeah. So I went to check in on her, and that really made an impact on her. That I was seeing if she's okay.
Yeah, that consistency, and it sounds like the meeting the client where they are, meeting them in some of the struggles. So going to the hospital if you found out she was hospitalized, or even I think the normalcy that we can provide as therapists when talking about suicide, not having this, oh no, like, don't want to talk about that topic, or we're gonna have to hospitalize you, just making it flow, and that it is normal. I don't even like the word normal, but making it feel that way for people is very important.
Yeah, she's so used to people pushing her away, being scared or abandoning her, that that created more of a sense of safety and support. And then when she's hospitalized, it was often when I was not on call. And so they were, some patterns of codependency, you could argue. Keep in mind, I was sorry every 2 weeks, but it wasn't like I was doing some old school psychoanalysis with her, stuff like that. But I think the consistency and the support. But again, I could broaden that to even here. One thing I like about Relixville is that I can still explore and address schemas, but then the whole team is working with them.
Right.
So I can point out schemas of emotional deprivation or defectiveness and shame, and Emma, the counselor, could be working on with them on processing those emotions and practicing good boundaries. So we have a whole team working with the person, and I can do one part of it and get the whole team. And I love that everyone here knows about the stimulus.
Yes. But yeah.
So it works really well in a team environment. It also works well in the addiction space, because we look at addiction as a developmental process, and the aspects of childhood, adolescence, and the adulthood that play to it. So I found it to be really effective in the work we're doing here. And again, gives the patient a lot of insight, a lot of a framework to work off of. It fits in with the warning signs that we develop with here. I always tell to the client, look at the 3 warning signs you're developing here, and consider what schemas might be in the mix or in the background, and it's helpful for them to differentiate that. I've also quickly add that there's these different schema modes we can get into. So that's more like these interpersonal states. So there's the default for most people is the detached self-soother. That's kind of person who looks like they're doing okay. They appear fine, but internally there's a whole storm going on, and that's like the default mode. And then what we're doing sometimes in these difficult interpersonal sessions is we don't often see the wounded child, kind of the client who's hurt and is vulnerable. There's an angry child mode that Jeffrey going to talk about, where they're reacting, responding, critical parent mode, or there's some trope. And so that gives them all these different modes is to get them to a healthy adult mode.
Yeah.
And processing them at what their age is. So the schema work does help you to look at these 18 schemas, look at the 18 schemas. They overlap quite a bit. And everybody has some of these or many of these. We're looking at how it then plays out interpersonally with these modes. And then you can give them lots of interpersonal, experiential, and cognitive behavioral approach strategies, interventions to help them change the parent. Empty chair could be used for a bit. I've done that before, but schema therapy, it works well with all these approaches. DBT works well with it. It's not like everything works well with it, but that's why I like it so much.
Yeah, because it's so all-encompassing that it's very malleable to different interventions and skills that we can put in practice, in place, in session, as we're navigating the different schemas. I also love schema therapy too. It's very similar in some ways to IFS, like of the different parts of self. I play on the wounded inner child all the time because that's a common part that you don't really get to see until we uncover, some of the parts or the schemas that are protecting the wounded.
I saw some of it when you did that presentation. I saw a lot of similarities in just different language use, but so that's a good model.
Yeah, it's helpful to uncover the deeper rooted issue, which too, when we're treating addiction from the model that we do, there's so much more to pay attention to and look at than just the alcohol, the drugs, or the gambling. Like we're focusing on that 100%. We're, emphasizing the importance of meetings and getting a sponsor and working a program of recovery. But in that program of recovery also comes with the underlying issues that precipitated the need to turn to alcohol, drugs, or gambling to numb, feel better, cope.
We're talking about the iceberg model. So the addiction is on the outside the water, and underneath the water, the huge part that we're addressing and we're chipping away at is all the schemas and the parts that are there, and that's also long-term work, of course. But I do think that fits with our model here. Yeah, and we can make some really good headway with an incredible team of clinicians. They're all coming at the issue from different angles, and then having that framework really helps.
Yeah. Well, what are some of the schemas that you find most often will coincide with addiction?
Yeah, I could easily list that off. Number one would be defectiveness and shame. And of course, you could argue that's from more recently. They could be feeling shameful and abducted because they're here. They're feeling the consequences of their addiction. But there's often a history of that feeling of not feeling good enough from early on, or it could be related to critical home environment. It could be experience of being bullied. Could have been different levels of oppression or marginalization. So there are all things that could be in the mix.
Right.
I see that a lot here with the folks here's defectiveness and shame. Related to that would be often a lot of abandonment schema with either losses in their life when they're younger, or marital losses, relationship losses, just grief in general.
Yeah.
People overdosing, but it doesn't what they know. So there's a lot of abandonment schemas that I've seen. Emotional deprivation kind of goes together with that. This experience of not having adequate nurturance and support or empathy growing up, so they develop like a hard shell on dealing with emotions, and it's to compensate for those feelings of defectiveness or mistrust or abandonment. On the flip side, we see a lot of folks here who are very, very intelligent, very high achieving. So I see a lot of unrelenting standards, hypercriticalness with them as almost a overcompensation for the work that I mentioned before. So this is like when they have very, very high internalized standards for performance and behavior for themselves and often others. And it creates where they're chasing something. Think about the proof of gambling. They're only chasing something and they get to it and they get excited and then it's fleeting. It's caught.
I need more.
It's more, but yeah, it's just like then and people around them are like, yeah, yes, you're doing great, you're great. And it's more pressure. So analytic standards is big here. And I would say some patients would have schemas of the title like grandiosity coming up from there. Some of that could be part of their personality, some of that with their experiences growing up, and a sense of, I can you can get around the rules, or at least they apply to me. And that maybe for some time that works and then it doesn't work. So that's we see that with the people here, narcissistic traits. And of course, the dependence, we talk about codependence all the time. So dependent schema, the sense that they're incomplete or unable to do anything without a significant other. They put all their eggs in one basket.
Right.
And I mentioned the mistrust of Yusuf related to Chala. So I was 18, those are the ones I think of, I see more often.
Yeah.
As approval seeking, that's one more I can think of.
Yeah.
You can see they overlap a lot.
Yeah, definitely.
And they're looking for that approval from maybe early on from their caregivers and then later on from their teachers, their mentors, their bosses, their spouses, their children. And it's like they lose sight of themselves, or who they are.
Right. And then maybe when they don't have some of those things anymore, they go through a divorce and they lose custody, or, then they feel completely lost. So it's addressing where is that need for approval coming from? Where are these things stemming from? To then figure out what to do about it, how to deal, how to move forward.
But lacking self-compassion, that's happening all the time. So it's that internal approval that's needed, or a sense of contentment that's hard to find for them and weird. But I think they feel so supported by not only all the incredible clinicians here, but also even sometimes the peers who are here. And then the staff in general here, they feel a sense of support, safety, comfort, connection. And then it's a foreign experience for some of them, and then they get really, trust that process and open up. They do really, really good work here. And then the hard part is in how can they recreate that beyond here and try to do the family therapy, and could be challenging, as you know.
Yes.
Yeah. That's I think the beauty of this program is that we have this increased awareness with the patients about these patterns. We're trying to, address the core underlying helplessness that drives the addiction. And then they leave here usually, hopefully, empowered with lots of coping skills, a lot of insights, and the key is for them to change those interpersonal patterns.
Right. Yeah. And as they're seeing, the schemas that they possess and how they carry them out, I think therapy in itself gets to be a corrective emotional experience. But the fact that we have the model of so many therapists, it's multiple corrective emotional experiences over and over with the staff, but then with peers too. So this being a place where I start to step out of being that approval seeker. I don't need to people please. I don't need to always say yes. I can start saying no, and I can set boundaries, and I can mess up and it be okay. And this is like a practice field almost with staff and peers, which I think is so cool.
Yeah, so even if a patient has an impasse with me, you get into something difficult and they have some transfer triasonomy.
Yeah. But yeah, I know sometimes as the principal, they like to call Sue every now and then, there can be those moments where you have a rift in the dynamic, having to enforce rules or maybe, bring to light lack of progress that we might be seeing, holding them accountable. So having other clinicians that then they can go to and process with, and then come back and see, I can have conflict with somebody and now we can talk about it and everything is going to be okay. You're not going to reject them. You're not going to abandon them, which those fears, abandonment, that's stuff that they're so scared of. So it gets to be that dynamic, which I think is so important. And all the work that you do with schemas really does impact a lot of our clients.
I remember an example where I had to have the conversation with a patient about our recommendations, and immediately there was a sense of him feeling closed off and feeling abandoned, rejected, baby shamed, and I'm doing my ethical obligation to convey our concerns. And it could have been in the past, but I paused and said, okay, let's move to schemas, and he was like, whatever, kind of look on his face. But then I started asking more about questions, and that even in that space, it's okay, it didn't go that way. It could happen where we talked about his depression and about some fears he had years ago, and the tone shifted to at least, okay, a little bit more trust, because again, the schemas helped him to feel understood, even despite that. It is my feedback that was not so positive, but he then was able to at least leave the session feeling heard of it. So, if it works well in the setting, because it gives a language. Yeah.
Well, thank you for joining me today, Lyndon, and talking with me about schemas. And thank you all for watching, and we'll see you next week.
Lady.